Moving on to a premature rupture of membranes, which we abbreviate as PROM. There's also PProm, which is preterm prom, right? So this is going to be the rupture of membranes that's happening in a preterm gestation. So there's PROM and PProm. So premature rupture of membranes is going to be prior to the onset of true labor, meaning my water is broken, but I'm not really truly in labor yet. That's going to be PROM. PProm is my membranes have ruptured and I am preterm, right? I am not full term yet. So that is going to be before 37 weeks gestation. So lots of things can cause this. Maternal infection is going to be a big one. Incompetent cervix, which I always think is like really insulting, right? My cervix isn't incompetent, but this means that the cervix is not doing a good job of staying closed, high, and tight, right? That's going to be more so that PProm. And then previous preterm birth, of course, predisposes you to another preterm birth. So the signs and symptoms are going to be, I'm leaking fluid. Now, I'm going to tell you a true story that happened to me because it's going to tell you why we need to do this next thing. I went to labor and delivery when I was pregnant with my son and said, I think my water broke. And I was pretty pregnant, like maybe 36 or 37 weeks. I said, I think my water broke. I've been leaking fluid all day long. And they tested the fluid that was leaking out of me and said, well, good news. It's not amniotic fluid. Your membranes are intact. You're just really sweaty. So if your patient reports that they are leaking fluid, we need to assess and see, are you leaking amniotic fluid? So we can do that a couple of ways. We can pH test the fluid. That nitrazine paper that we would use to test the fluid would turn blue in the presence of amniotic fluid. So that blue color would mean, yeah, that's amniotic fluid. And then a positive ferning test where the fluid is examined under a microscope, and if it has like fern-like crystals, then that would be amniotic fluid as well. Treatment here. We're going to give ampicillin to treat any possible infection, and then we're going to give betamethasone, which is a steroid, to help promote fetal lung maturity. So if we're preterm and we think maybe we have a little bit of time, even if we can just get one dose in, we're going to help to promote fetal lung maturity with the betamethasone. If it's preterm, they're staying in the hospital, to be observed, or they can go home on bed rest, which would mean like no intercourse. You're taking your temperature every 4 hours, and you got to report any signs or symptoms of infection. But if they are near term, or if they are at term, then they're probably just going to be induced, so that we can get baby out and not be concerned about things like infection anymore. So biggest risks here again: infection, prolapsed umbilical cord. Anytime those membranes have ruptured, we can end up with the cord being prolapsed, and we can end up with germs getting inside. So let's move on to preterm labor. I see some big bold red stuff here, so I want to point that out. So preterm labor is going to be any kind of uterine contractions that cause cervical changes between 20 and 37 weeks of gestation. Remember, we have Braxton Hicks contractions. Those are not true contractions. They're not affecting the cervix, but we're talking here about contractions that really are affecting the cervix. So risk factors: infection, diabetes, hypertension, smoking, multifetal pregnancy, PROM, placenta previa. There's so many. Previous preterm delivery, like we said, there's a lot of risk factors. But the signs and symptoms of preterm delivery or preterm labor, like we said, is going to be cervical dilation, vaginal discharge of amniotic fluid, and uterine contractions. Those are the big three there. But there's a very special lab test that can be done. If we think a patient could be in labor, or maybe we're concerned that they might go into preterm labor, a test called fetal fibronectin can be done. And fetal fibronectin is an amniotic enzyme. And if it is detected in a swab of the vagina, then it can correlate to, yes, you are at risk for preterm delivery. If we do not detect it, if we have low levels, based on gestational age, then we can say with pretty good confidence that you are unlikely to deliver in the coming days. So this is a really great test and can help to assess a patient's risk for preterm labor. Now, if we were to give magnesium to our patients to relax the uterus, that's something that we can do to slow those contractions down. We would need to be concerned about magnesium toxicity. So we should be assessing those deep tendon reflexes, assessing their respiratory effort, and knowing that the antidote for magnesium is going to be calcium gluconate. So we need to be ready with that if we have any concern of magnesium toxicity. Nifedipine is also a medication that's a calcium channel blocker, and it can be given because it's going to help to relax that muscle. That's how it works to decrease blood pressure. So it's going to help to relax muscle, including the muscle of the uterus. So that is an option as well. Terbutaline, we've talked about before, is a tocolytic, so it's going to help to relax the uterus. Indomethacin is also an NSAID actually that can help to suppress labor. And as we discussed before, betamethasone to improve that fetal lung maturity. Now, if our patients are going to be on bed rest or anything like that, we need to explain to them what that means, and that also they are on pelvic rest, so no sexual intercourse is going to be allowed during this time. So I hope that review is helpful for you. I'm going to give you a patients. Okay. So let's move on to hydatidiform mole. From here on out, I'm going to call it a molar pregnancy because that's a mouthful and I don't want to keep saying it. But a molar pregnancy is very rare, but a serious complication. So this is abnormal growth of the trophoblastic villi in the placenta, which prevents normal embryo maturity. So when we see this on ultrasound, I always say that it looks like TV static. There's just nonsense in the uterus. It is just black and white craziness. Some other places will describe it differently, like it will look like grape-like clusters, and maybe it does, but that's always what it looks like to me, is like TV snow or TV static on the ultrasound. Now, your patient may have dark vaginal bleeding, and this may be described as a prune juice consistency or color. So it's kind of that like dark brown, purplish color. That should be making you think this might be a molar pregnancy. Your patients, if maybe they were undergoing artificial reproductive therapy or something like that, and they might have been having HCG levels, you likely would have seen that those pregnancy hormone levels were growing at too high of a rate, and that is very classic for molar pregnancies. So we can diagnose this on ultrasound. Like I said, there's a very classic look to it, and unfortunately, the treatment for this is DNC. This pregnancy is abnormal and cannot ever be be normal, and it needs to be removed from the uterus entirely. Not just that, but then your patient needs to have HCG monitoring to ensure that their levels return to zero, that it goes back down to normal. For 6 months after the D&C, they're actually going to have that HCG monitoring, and then you're going to teach your patient that they need to avoid pregnancy for 1 whole year because the pregnancy and HCG levels rising would make it difficult to monitor for something called a choriocarcinoma. So chorio referring to the chorion, that part of that developing placenta, and carcinoma is cancer. So if your patient has a molar pregnancy, they are at risk for developing a choriocarcinoma, which means that we need to monitor those HCG levels, and a pregnancy within that year would make it impossible for us to monitor those appropriately. So this is a rare complication, but a very important one to understand. Okay, lastly, in this video, we're going to be talking about ectopic pregnancy. Now, ectopic means like outside of. This means a pregnancy that is not growing in the correct place. And the only correct place for a pregnancy to grow is in the uterine cavity. So it is not okay for a pregnancy to grow in the fallopian tubes, any portion thereof, or outside of the uterus entirely, where it's actually growing in the abdomen or the pelvis. This is a rare complication of pregnancy, to have it grow completely outside of the reproductive organs, but it does happen, and it can happen. So if I have a pregnancy that's growing in the wrong place, it's not going to be in this organ that allows it to stretch and grow normally. This is going to be something that cannot be brought to life, right? This pregnancy will not develop normally, and also puts the patient at significant risk for complications, including hemorrhage and death. So what does the patient look like if they have this? Well, first of all, hopefully they came in early for their pregnancy, their first pregnancy visit, and we could see it on ultrasound. If not, your patient is going to likely report unilateral, one-sided stabbing pain in early pregnancy, somewhere between that like 5 to 9 weeks. If you have a patient ever, regardless of their pregnancy status, if you have a woman of reproductive age, of childbearing age, who presents with unilateral stabbing pain, you need to think ectopic pregnancy until proven otherwise. This is a deadly complication of pregnancy, and it is very important to catch it as soon as possible. So there are a couple of ways that this can be treated. One is methotrexate. Methotrexate is a medication that can be given to the patient that will actually cause the pregnancy to end and for the body to absorb it. The other is surgery. The patient can have surgery to remove the pregnancy, especially if they already ruptured that tube or they are about to rupture that fallopian tube. This is very, very dangerous for this patient, so we can't wait for the methotrexate, basically. We need to get that pregnancy away from the tube so that our patient does not hemorrhage, go into shock, and die. So these are some very scary complications of pregnancy, but it's very important that you be aware of them so that you understand what can happen to your patient and understand what to look for in those cases. I hope this review was helpful.